or what is the abnormality. Okay, for the benefit of everyone, I can understand it is a lot of theory for everyone to be able to digest. So that's why I will try to show you some pictures and summarize the whole cardiac examination in a few minutes. Quick synopsis. So as you may see over here, these are the different anatomical landmarks. This is very important when you are trying to place the ECG, when you are trying to do the palpation or the auscultation as well. Where is the murmur? Where did you hear? Where was the thrill? Did you feel? Where was those different pulsations as well? And then after that, as I had already said, it is in the examination, you try to look for the jugular venous pulsation, inspection, palpation, and auscultation for in the 4 cardiac areas, which I said it, the aortic area, pulmonary area, tricuspid area, and the apical area as well. And then you try to do the auscultation over the tricuspid and mitral areas with bell over there. And sometimes you may need the help of special maneuvers. So if you're not able to, have a palpation, for example, of the apex. So what you do is you can ask the patient to lie down in the left lateral position. It might be a little bit better and easier. Similarly, for a patient of aortic regurgitation, you have to put the diaphragm of the stent to the left lower sternal border with the patient sitting and fully exhaled for aortic regurgitation. And why is it important is, as I'm telling you, when you will be having MRCP exam in one of the stations, they will ask you, expecting that this is a patient of aortic regurgitation, how will you auscultate? Show it to us. This is what will be asked. So similarly, if there is a patient of mitral stenosis, that is the time you will again use your bell of the diaphragm, bell of the stent, and in left decubitus. So this is very, very important. So once you have done, I'm going to now show you some pictures. So we all have already been through the theory. What is happening over here? Can someone would like to summarize? What are we trying to do? And what are the position? Why are we doing it like this? We have already been through. As I'm telling is like, now I'm trying to summarize it for the benefit of everyone. Let the pictures do the talking. You all are now James Bond. Dr. 007. Doctor, what is being done? What is happening? So if you may notice, the inspection is being done of what in that area. So it is for the jugular venous pressure. A jugular venous pressure, normally, as you may notice, the patient is lying down with the head tilted to the left side. And the patient is, if you may notice, that the patient is elevated to the point where jugular venous distension is normally seen in the mid neck. So that's where the doctor's finger is pointing to. And yes, if there will be a patient with a markedly elevated jugular venous distension, you will be able to easily see it. And if you want, you can even ask the patient to sit upright. Or in a patient with low normal jugular venous pressure, this may need to be at 0 degree to see the distension in the mid-neck. But remember, the rest of cardiac examination should be done at the patient being at 30 degrees. Now, next quiz session. What is happening here? I'm such a nice person. I have already given the clue over here. So there's inspection and palpation. So inspection is already done. What is happening here? So inspection has been done. Okay, so on the right side, you tilt the head to the left. The patient is already elevated, if you may notice over here, and it is a female patient, as you may see it over here. So you are doing the inspection, palpation, and auscultation for rest of the cardiac examination at 30 degree, which you may already notice over here with the bending of the neck. And you try to inspect in all the 4 areas and palpation of the aortic area. So where is the aortic area? So if you may recall, this is the right second intercostal space just lateral to the sternum. So let's move to the next one. What's happening here? Oh, I already made your task easier. So what is happening over here is, come on, you just need to read out. So what is happening over here? Come on, anyone? Okay. Only one. Come on. Is it so difficult? Come on, have a look and tell me. So, see, Lance is so smart. Palpation of the P valve. Was it so difficult to read? But why do you call it as pulmonary valve? I would say it is tricuspid valve. How will you defend your point? See, knowing the right answer is not enough. Now we try to emphasize on knowing the logic behind it. Why? What is the reason? Why? What? How? Questions. Wonderful. Very, you really make me happy. Good. Very right answer. As you may know, the pulmonary area is the one which is there in the left second intercostal space, just lateral to the sternum. Very good. I said it. My students are so intelligent. I'm proud of you guys. I mean, guys and girls, of course, everyone. What is happening now here? So I have already written palpation of the right ventricle and the tricuspid area. So this is the area which is in the lower left sternal border. Now, what is being done over here is palpation of the apical area. So as I already said it is, if apical impulse is not palpable, ask the patient to change to left lateral decubitus, and palpation should be done with the finger pads. It should not be, done with this, with the finger pads in all the 4 areas. And palpation of the apical areas about, okay? So this is very, very important. And the palpation of the apical area about 5th intercostal space in the mid-clavicular line, it should be done. So as I was telling you, if it is a difficult patient, you should try to go to the left lateral decubitus ask them, get a consent, always update them. What are you trying to do? What are you expecting? And always keep on observing the patient as well. Yes, if the patient feels discomfortable, is not at ease, always try to make them comfortable. This is one of the most important thing is whenever you're trying to deal with patients or anyone, they all are living humans, right? It's not an object or a doll or something. So you have to be conscious to be able to take the care of them as well. Okay. So now coming to the cardiac auscultation. Cardiac auscultation is being done, no doubt, as you all can see. So now what is happening here? So if you may recall, I had said it, there will be some areas where you auscultate with the diaphragm, and there will be some areas where you auscultate with the bell of the stet. This is the reason any of the stets will have two different components, a diaphragm and a bell as well. So what are the areas you auscultate with diaphragm and with a bell? So you can already see. So what is happening over here is that was with a diaphragm, and here is with a bell. So with the diaphragm, you auscultate in the aortic area, pulmonary area, tricuspid area, and also in the mitral area. And the patient should be in sitting and left lower sternal border with fully exhaled. Why did I ask for that? Try to appreciate the findings of the splitting as well. Is it physiological? Or sometimes, as I had said, it is, there may be additional heart sounds like the S3 or S4 as well. So you should be able to differentiate that as well. And with the bell, okay. So with the bell, what are those areas? So with the bell, you auscultate in the mitral area, as you can already notice, and mitral area again in the left, a lateral decubitus position. How do you do it correctly? It is not like this, just you put it and you are done. No. So to do it correctly, you apply the bell with light pressure. So that's why you can notice over here, the doctor is holding the bell well and applying gentle pressure. And it should not be heavy. Okay. So remember, especially for the newer stet, diaphragm is lightly okay. And with a bell, then you finally also go to the tricuspid area as well. So after doing all these things, you try to auscultate with the diaphragm at the lower left sternal border. Now, not to be sexually biased, okay? There are some pictures also from the other side. So you try to auscultate with the diaphragm of the left lower sternal border with the patient sitting and fully exhaled. And this is the optimal position to listen for the aortic insufficiency or the aortic regurgitation. But yes, this is a different patient, I'm sure you can understand. So, are there any further questions?